Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Ben Thrower, who will be providing us with a COVID-19 update. After his presentation, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center, and that's in Atlanta. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow, the pirate, he can be found playing with both of his grandchildren. He just has a new one. And anyway, I'd like to turn it over to you. Thank you so much for being with us today.
Great. Thanks very much. Thanks, Deb. And thank you to everyone behind the scenes at MS Focus. I say this all the time, and I truly mean it. You guys have done an amazing job of carrying on and adapting and actually improving upon all of the educational programs that you offer to the MS community. So we thank you for all of that. So who would have thought that 2 years ago, when the COVID pandemic started, that we would still be doing these updates at this point. And I know we all look forward to a day when these are no longer necessary, but we're not there yet. Maybe we're getting closer. So what I wanted to do today, before we turn it over to the audience for questions and comments, is really hit on 4 topics. I wanted to talk about just kind of COVID broadly, where are we at in the United States right now with COVID. I want to talk a little bit about therapeutics, talk some about what COVID means for the MS community, and then touch a little bit on the concept of long haul COVID and this, what does that mean, and what do we know, and where are our knowledge gaps right now. So every time we think we've got COVID figured out, it throws a little curve at us. Viruses mutate, and so we are always learning new things with COVID. Right now, most of our focus is on the Omicron variant, as I'm sure all of you know. So through the summer, through August, September, October, we were dealing with the Delta variant. Delta was no joke. Delta was very serious. It was more contagious than the original COVID, than the Alpha variant, or original COVID Alpha, and it was also more virulent. It caused more illness. So then along comes Omicron, and Omicron as a variant changed quite a bit. It has at least 42 mutations at the COVID spike protein. It probably has picked up some genetic material from other coronaviruses, more common coronaviruses. This is probably a good thing in some ways. So Omicron has been spectacularly contagious, but fortunately milder. I don't want to harp too much on the mild part. There are clearly people who are still getting sick, and it is Omicron is causing misery, but it is not as serious for the average person as Delta was. Some of that appears to be because Omicron seems to be more of an upper respiratory problem. A lot of headache, a lot of nasal congestion, sore throat, some fever, but probably not as impressive as what we saw with Delta. Maybe less of the loss of sense of taste and smell. Again, very, very contagious. My wife's pediatric office around the holidays, with people traveling, there were lots of kids and teenagers who needed to get COVID tests for traveling. And so these kids are coming in and getting COVID tested, and many of them were either asymptomatic or very mildly symptomatic. And so many of these kids were testing positive. So it had the potential to be asymptomatic. Good on one hand, in that the person didn't feel so poorly or felt fine altogether. Challenging on the other hand, because they were probably potentially contagious, and so they were spreading it around a fair amount. It does appear that we have hit our peak and are on the downhill side of the Omicron variant. As of, I know, late last week, 49 states in the union we're seeing declining numbers. Alabama was the exception. Hopefully they've turned the corner as of this week. I know here in the Atlanta metro area, we were one of the original hotspots. We were a hotspot. Miami was a hotspot. So we kind of did our Omicron dance early. And so we seemed to hit our peak about 2 weeks ago. And again, the numbers are coming down. You are hearing some rumblings out there about stealth Omicron. This is not a new variant. This is a sub-variant of the original Omicron. So within these variants, you can have little minor tweaks, so it doesn't qualify as a totally new variant. For instance, with Delta, by the time we were at the peak of Delta, there were probably 500 sub-variants of Delta out there. It doesn't look so far like the stealth variant of Omicron is doing anything much differently. God willing, it's not going to throw another curve at us. I think what we don't know is what do we look like in a month or 2 months. There is hope that maybe Omicron has outcompeted Delta, that Delta is gone at this point, but I don't think we know that for sure yet. There is some suspicion that so at its height, it was said that about 99% of cases that we're seeing in the United States were Omicron, that has been some pushback on that data saying that maybe some of those Omicron cases were mislabeled, that they were actually still Delta cases. So I think we'll know more over the next few weeks and couple of months here as to whether Delta is really gone. I think it's really very important that we know that, because it has implications for how we think about going forwards with mitigation strategies. What do we do to try to keep ourselves and others safe? And it would be nice if we had a crystal ball and could say, well, Delta's gone, or it's not gone, or there's something else on the horizon that might look like Delta in terms of making people sick. But obviously we don't have that perfect crystal ball. So we do now have some therapeutic options. So when we think about the evolution of our human response to the pandemic, so we went from focus on masking and social distancing, sort of trying to stay away from other sick people, staying away from crowds, because really that's all we had early on. And then we come into the era of vaccinations, still very, very important strategy for helping us push back on COVID. And then we start seeing the therapeutics come along. So some of the initial therapeutics were the monoclonal antibodies. So what is a monoclonal antibody? Well, a lot of us are familiar with monoclonal antibodies in the MS community because we have MS therapeutics that are monoclonal antibodies. These are engineered antibodies. So, when you think about natalizumab, ocrelizumab, that MAB on the end of those MS medications stands for monoclonal antibody. So when we say monoclonal, we mean that it does one very specific thing. It hits one target. The contrast to a monoclonal antibody would be a polyclonal antibody, antibodies that hit a variety of targets. So if you have a natural COVID infection, you generate a polyclonal antibody response. Your immune system makes antibodies that might hit COVID in a lot of different areas. A monoclonal antibody was engineered to really hit one specific target. So we do have several FDA authorized monoclonal antibodies. So this is that same emergency use authorization that the vaccinations were initially put into the public under. So it's not FDA approval, it's a recognition that there's a pressing need. And so these monoclonal antibodies have not gone through all of the paperwork hoops. They've still been studied and evaluated for safety and effectiveness, but they've not gone through all the usual FDA processes, paperwork processes for formal FDA approval. They probably will get FDA approval at some point. So the original monoclonal antibody that most of us heard of was Regeneron. This was the one that when President Trump was president and he got COVID, he's hospitalized at Walter Reed, he was treated. So Regeneron was in its early testing phases then, and that's what Trump was treated with. and obviously worked well for him. So Regeneron got FDA authorization in December, and then interestingly, the FDA took the authorization back. So they didn't take it back for any safety reasons. They took it back because it doesn't appear to be effective against the Omicron variant. So these antibodies were really designed with the original COVID variant or the Delta variant in mind. So they were kind of designed pre-Omicron. So now Omicron comes along and the question is, okay, the virus has thrown a little curve at us. Do these monoclonal antibodies still offer effectiveness against Omicron? Regeneron does not appear to offer much against Omicron. You could argue, was it wise to pull the authorization for Regeneron? I think it's a theoretical question. What if Delta is still out there? And maybe 2 months from now or a month from now, Omicron's gone, but maybe Delta rears its head again, and Regeneron does appear to be effective against Delta. Maybe we want that tool in our arsenal still to not for Omicron, but for something else. We do have the Evoshield product, and then another monoclonal antibody called sotrovimab. Sotrovimab probably has the highest degree of effectiveness against Omicron, and it also gives great Delta coverage. I don't know about nationwide. I know in the Southeast, the sotrovimab also seems to be the hardest of the monoclonal antibodies to get our hands on. Here at Shepherd Center, we put in a request for sotrovimab back in late December, early January, and we have yet to see a single dose. Other hospitals do have it. We were able to get our hands on Evoshield. It's Evushield. So Evoshield is authorized by the FDA. It does have great effectiveness against Delta, and it offers modest effectiveness against the Omicron variant. What's interesting with Evoshield, so when you think about these therapeutics, they're authorized to treat people who have a COVID infection. So if you're really, really sick and you need to treat that person, you can use one of these monoclonal antibodies. Evoshield is also authorized to potentially prevent COVID infections. And we're going to circle back to that in just a second. So what might that mean to the MS community for thinking about Evoshield as a preventative? So then we also have the oral antiviral therapies. The one that is most commonly thought of is Paxlovid. Paxlovid is a Pfizer pharmaceutical product. So these are oral medications that are used to stop the virus from replicating. So Paxlovid is a 5-day course of a pill. Appears to be fairly effective. So if you had a really symptomatic case of COVID, you could think about treating it and shortening the duration with one of these therapeutics, either a monoclonal antibody treatment or one of the oral agents. Remdesivir would be another therapeutic. That's the one that's probably been around the longest. If you're talking about something in the outpatient setting, you're probably not going to see remdesivir used in the outpatient setting. Usually it's reserved for people who are pretty sick, ICU type admissions in hopes of shortening the duration of the ICU stay or saving the person's life. So what does all of this mean then for people with multiple sclerosis? So we know that, and going back to the real basics, we know that MS does not by itself suppress your immune system. And it bears repeating that MS by itself does not put you at higher risk for COVID infection or a worse outcome with COVID. So you have a relatively overactive immune system if you have multiple sclerosis. Now, if you have other health issues, diabetes, hypertension, obesity, tobacco use, then those comorbidities could potentially put you at higher risk for COVID or getting sicker with COVID, but the MS by itself does not. When we think about therapeutics for MS, that's where we have to start looking at the potential that maybe we change that dynamic. So certain MS therapies, because of the way that they work, could potentially compromise a person's immune system. And the ones that we tend to think about the older platform therapies we're really not worried about. Your interferon therapies, your Copaxone, not so worried about those. We've really seen no issues with Tysabri or natalizumab. We've really not seen any issues with the dimethyl fumarate or Tecfidera products, or the kind of the spinoff of Tecfidera, Vumerity. Really not seeing any big issues with Aubagio or teriflunomide. The ones where we have to think a little bit about the potential for altering immune function and potentially putting a person at higher risk for COVID would be your B cell therapies. So that's going to be Ocrevus, Rituxan, Kesimpta. Your S1P modulators, so that's going to be Jolenia, Ponvory, Zeposia, Mayzent. And then I would argue that Mavenclad, very, very effective oral therapy. On paper, you would think it might have, potential for immune suppression in a way that could put a person at higher risk for COVID. But I would say that the data so far doesn't seem to be bearing that out. So Mavenclad, I put in that list, but I would say in reality, we're not seeing big issues. And then Lemtrada, one of our more potent IV therapies, I think we would have to at least think about potentially lowering immune function and putting a person at higher risk. What do those therapies do for vaccinations? So how do they affect vaccine responses? The two that we've been most focused on are the B cell therapies and the S1P drugs. So with the B cell therapies, Ocrevus, Kesimpta, Rituxan, clearly we've learned that those drugs can decrease the ability for you to mount a good antibody response to vaccination. What some studies have suggested is that maybe 50 to 60% of individuals who were on a B cell therapy at the time of COVID vaccination are not making a good antibody response. That said, realize with vaccination that there are two parts to a vaccine response. There's a T cell response, and then there's a B cell or antibody response. The T cell response in patients on B cell therapies does not appear to be affected by these therapies. So if you get your COVID vaccination, you're on Ocrevus, Rituxan, Kesimpta, you should still mount a good T cell response to that vaccination. The challenge that we have in the real world is we don't have a great blood test to measure that. So research says you get a good T cell response. We believe people do, but we don't have really a great way of confirming that, just because there's not an easy commercial test available to measure that. When we've measured B cell responses, so antibody responses to COVID vaccination in our patients on Ocrevus, Rituxan, Kesimpta, we're finding more like 80 to 90% of our patients are not making a good antibody response. Again, we know they make a T cell response, but they're not making much of an antibody response. So the Jolenia, the S1P type drugs, Jolenia, Mayzent, Zeposia, Ponvory, those patients can also have a decreased antibody response to COVID vaccinations. And that's the other group that we need to sort of be aware of. So what do we do with that information? Do I think that it's still a good idea for people with MS to get vaccinated and boosted? Yes, I do. So we know with the Delta variant that people who were vaccinated tended to do better. Even if they got the Delta variant, they tended to have a milder course. And that was shown in study after study. If you looked at people who were hospitalized, they tended to be more unvaccinated individuals. I don't think we have the final answer at this point on fourth doses of vaccinations. The study in Israel in people who had normal immune systems said that they didn't see a lot of a big benefit to fourth doses of a vaccine, but I think the jury's still out at this point. I don't think we're ready quite yet to widely recommend fourth doses. So what do you do if you're on an MS therapy and you didn't make a good antibody response? Again, we can do the blood test. We can see if you made a good antibody response. That's where the Evoshield comes in. So we do know that if you didn't make antibodies because of your MS therapy, we can passively give you the antibodies. So that is what Evoshield is authorized for, is to potentially use as prophylaxis. So if we give you a dose of Evoshield, it's not a vaccination. We're not asking your immune system to do anything. We're just passively giving you these antibodies. So Evoshield is 2 intramuscular injections, one on each hip, administered at the same time. So, if you are on a B cell therapy or on one of the S1P oral therapies, talk to your healthcare providers about that. Honestly, I'm a little bit more concerned about the B cell therapy patients than I am about the S1P drug therapy patients. It's still a conversation worth having, but I think the big focus should probably be on our Ocrevus, Rituxan, Kesimpta individuals. So we are offering the Evoshield product to individuals on one of those therapies. It's a hard decision because, again, we don't have that crystal ball to know where we're going to be at in 2 months. If you could tell me that Delta is gone, that Omicron has wiped Delta off the face of the earth, and that once Omicron's gone, we're done with this, I probably wouldn't worry much about getting a dose of Evoshield. I don't know that though, and because there is some potential that maybe Delta is still working out there, that's why we're offering this Evoshield product to individuals on one of the B cell therapies. Again, it does appear to offer really good Delta protection, and it offers you modest protection against Omicron. And that protection, these from the Evoshield product, probably lasts for 6 to 8 months. That's going to give you that passive antibody protection. So then, kind of shifting to the last thought is, we have a lot, millions of Americans have been infected with COVID, and some people don't seem to be bouncing back quite as quickly. And so this concept of long haul COVID or long COVID is something that is evolving. I don't think that there's a strict definition. So how long do you have to be symptomatic after COVID to say, okay, it's long COVID? Most people would probably say if you're still having symptoms a month out, 2 months out, well, that's probably longer than you would expect with the typical viral infection. So what are the symptoms that we could see with long haul COVID? It's a basket, and there's a wide variety. So anything from ongoing fatigue, cognitive fog, cough, shortness of breath, any of the aches and pains that just keeps lingering on and on. There is not agreement within the scientific community about what the underlying cause of long haul COVID or long COVID is. There is some evidence to suggest that maybe it's an autoimmune response, that antibodies, autoantibodies could be playing a role here. There is some evidence to suggest that maybe viral particles that are still sort of circulating and still making your immune system react in an inflammatory fashion, maybe that's the cause. Maybe in some people it's a little of each. Maybe in some people it's one of those, and in other people it's the other. So I don't think we know quite what the underlying etiology is for everybody with long haul COVID. There was a study that came out of Swedish Medical Center in Seattle that looked at potential predictive risk factors, and that what they showed is that type 2 diabetes seemed to be a risk factor for some people. Interestingly, in their study, the presence of Epstein-Barr virus circulating in the bloodstream was associated, at the time of your COVID infection, was associated with a higher risk of long haul COVID. And they didn't know quite what to make of that. Does it mean that you were sick with COVID and that allowed your Epstein-Barr virus, which most humans carry, to sort of manifest itself, and that it was just an epiphenomenon? It really didn't contribute to your long haul COVID. It was just a sign that you were sick. Or does the Epstein-Barr virus somehow dance with the COVID virus in a way that puts people at risk for this? I don't think we know the answer to that yet. The degree or severity of your COVID infection may be, to a certain degree, predictive of your risk of long haul COVID. So if you were mildly symptomatic, maybe that's you're at lower risk for long haul COVID. Most of this data on long haul COVID was collected during either the original COVID pandemic or during the Delta surge. We really don't have as much data on Omicron. There is a hope that maybe because Omicron played more nicely with the human body, was less virulent, that maybe there'll be a lower risk of long COVID type symptoms with Omicron, but I don't think we know that quite yet. So we've come a long ways, over the past 2 years. I think all of us pray that we're getting closer to being done with this. I think there's a very real possibility that the COVID virus doesn't ever truly go away, but hopefully it morphs and changes into a way that it looks more like other common coronaviruses. Humans have lived with coronaviruses since the beginning of humanity. They've been more common cold type coronaviruses. They've been nuisance coronaviruses. If COVID evolves into a nuisance, I think we would all agree that we can live with that. We can't live with pandemic for forever. So I will stop with that. I'm sure there's something that I left out, and you guys always have wonderful thoughts and questions. So let's open it up to the audience.
Okie dokie. Let me tell everybody how to do that. So now that we are ready for questions, I'd like you to know that if you have one or you'd like to make a comment, you can use the raise hand feature in the app, or you can send your question via the Q&A app. If you'd like, you can even type in your question and make it anonymous. Just let us know. Let's go with the very first one. So you did answer the very first one, so we'll go with the second one. Just to clarify, Caroline would like to know, does Jolenia depress the T cells or both T and B cells? And is there an antibody test to check effectiveness of the vaccine and a booster?
Yeah, great question. So Jolenia and the other drugs in that class, and again, the other drugs would be Mayzent, Zeposia, and Ponvory. These drugs sequester T cells in the lymphocytes. They don't have a dramatic effect on B cells, so there's really no effect on antibody levels in patients on these drugs. So, and it's important to note these therapies are not killing any cell; they're just locking them up. So when lymphocytes are circulating through the lymphatic system, they go into lymph nodes and they're basically programmed in the lymph node. They're given their job in life, and then they don't passively leave the lymph node. They have to be given permission to leave the lymph node. And what Jolenia and its cousins do is they don't give some of the lymphocytes permission to leave the lymph nodes. They lock them up. They're still there. So if you do a blood test, a complete blood count in someone on one of these drugs, their lymphocyte count is going to be very low, but it's not really low. The cells are there, but they're locked up in the lymph nodes. We don't have a great commercially available test to measure T cell responses to vaccination. There is one out there. There may be more than one now. The last that I looked, the one that was available is called T Cell Adapt. And it is a test that was approved to look at T cell responses to COVID vaccination. The problem is it's just not available. We had our lab look into it. It's very difficult to get it. Insurance companies are not covering it. It's expensive. There's only one lab in the country that's doing it. So it really is more of a research tool right now than something that we can use to actually measure T cell responses. The good news is that every study that has looked at how people on various MS therapies respond to COVID vaccination or to natural infection, no study has shown altered T cell responses to either to vaccination or natural infection.
Elizabeth wants to know, when would you consider a re-vaccination, the fourth dose after Evoshield or maybe MAB3?
Yeah, so if you've had so if you're boosted, and let's assume that you're not on one of the therapies that could alter your antibody response. I mean, you should be good after your booster for 6 months, 8 months. And the The CDC has not made a formal recommendation yet on another booster dose, so a fourth dose in that setting. Where it gets trickier is what if you're in the group who didn't make a good antibody response? So you've been boosted and we do a blood test, say you're on a B cell therapy, we do a blood test and you didn't make antibodies. And this is my own personal thought. I don't know that doing a fourth dose is going to change that dynamic. So if you didn't make any measurable antibody response with 2 vaccines and a booster, I don't know that a fourth booster or fourth dose is going to be the magic bullet. So that's where I think Evoshield comes in. If you're not making antibodies after your booster dose, let's just give you the antibodies. So now I've given you the antibodies. We think that's going to cover you for 6 to 8 months. I personally, and this is all brand new, we just started doing the Evoshield in December. Personally, what I would do is, let's say COVID is still rearing its ugly head into the summer. I would repeat the blood test for COVID antibodies. If they're starting to go away, then do another dose of Evoshield at that point.
And Judy would like to know, are there any ongoing studies looking at an increase in autoimmune disease or exacerbation of such as MS, thyroid, alopecia areata, not just long haul COVID responses in general?
There are a number of groups collecting data out there. I mean, the UK is collecting a lot of data on, looking at what long haul means. And again, is it autoimmune? So if long haul COVID in some people is actually an autoimmune response, what does that mean for someone with MS or another autoimmune condition? I don't think we know the answer to that. There's also ongoing safety monitoring with COVID vaccinations. Are we seeing any increase in autoimmune conditions after COVID vaccination? There was a study that looked at how people with multiple sclerosis respond to COVID vaccination, regardless of the product, versus the non-MS community. And at least in the study published about 2 months ago, they didn't see any difference in how people with MS respond to COVID vaccination in terms of side effect risk versus the non-MS community. So, a person with MS can certainly feel crappy and achy and tired and have low-grade fever after a COVID vaccination or booster, just like the non-MS community did. Now, in someone with MS, if you get a low-grade fever after COVID vaccination or booster, there's a chance that you could have a pseudo exacerbation. So we know that when your immune system revs up, whether it's due to a real virus or to a vaccine, maybe imitating a virus, your old MS symptoms could act up temporarily. So, and I definitely have seen that. Heavy emphasis on temporary, though. These people, as soon as the post-vaccination side effects go away, people are typically feeling better. I think one of the challenges with this whole COVID pandemic is, I don't care where you stand on the vaccine issue or on what you want to do, there is no zero risk option. So everything is about weighing the risks and benefits of every one of these options and just trying to be as educated as you can and look at your individual lifestyles. The answer that's right for one person, if I have someone who is really socially isolated and not going out anywhere, well, their risk is probably lower than my patient who's a school teacher and is around tons of people every day. So I think it's we have to take all that data and the person's individual risk tolerance and put it together to come out with a game plan for the individual.
We have a couple people who have raised their hands, so we're going to let Karen speak now. Let's unmute her. Let's see.
So,
Casey, are you able to unmute Karen?
I just did. Can you hear me now?
Yes.
There you are.
Thanks for your patience there. Thank you so much, Dr. Thrower. This is just amazing information. It's fairly specific, but I think a lot of us are probably in the same boat. I take Kesimpta. I tested myself through Quest, and as of December 6th, with my last dose of Pfizer being in August, I had a 4.61 in the positive for COVID spike antibodies. But the hospital that I get my treatment through is offering me Evoshield, but not saying that they would test me for antibodies prior. They're just doing it based on the medication that I take. And so it's just as you had said, it's a decision to make about the efficacy of whether I need that. And I'm asking you the risk benefit. If I were to take it, and but I already have antibodies from vaccination, is there any downside, or would it be just more of a good thing?
Yeah, great question. So assuming that the lab is using the Mayo Clinic assay for your COVID antibodies, so where it's easy is if they come back and say negative, so you have no antibodies. Where it gets a little trickier is if you have antibodies, because then you get into the numbers like you were saying. And Mayo, like most labs, is very careful to put a disclaimer on that lab and say, we don't know for sure what number is actually protective. Clearly, when you get up into the thousands, with your COVID antibodies, that's probably better than having a lower number. If that's the Mayo Clinic assay, that is your number is at the lower end of the positive range. I totally get where the hospital is coming from and saying, listen, we're just going to offer it to anyone on B-cell therapy, because statistically, most people on B-cell therapy are going to not have an adequate antibody response. I don't know of any negative to having too many COVID antibodies. No one has shown any downside to that. Granted, there's not a lot of data out there, but I would tend to err on the side of being more protected than less protected. So Evoshield, the side effect risk is generally low. There have been allergic reactions. So when you do your dose, the nurse is going to want to watch you for anywhere from 30 minutes to an hour, depending upon the facility, just to make sure you don't have an allergic reaction. There have been some headaches reported after it. I had a woman have about 48 hours of a headache afterwards, but that's been about the worst of it. So again, it's not a vaccination. You're not going to see that, the really crappy feelings like you see sometimes with vaccination, because it's passive. We're just giving you these antibodies. We're really not asking your immune system to do anything. So I would say my bias for our individuals when we're having this discussion is I'm erring on the side of wanting to do the Evoshield for individuals.
Okay, so there's nothing, just in theory, that adding more antibodies into my system is going to further exacerbate my autoimmune disease.
Correct, because these are antibodies that are very specific to the COVID spike protein. So Evoshield is actually 2 monoclonal antibodies put together, but they both only target a region on the spike protein. So they're not doing anything else immunologically.
And then they dissipate in time, as you had said.
Correct.
Okay, and there's no residue from it. Okay, thank you.
Yeah, absolutely, thank you.
Thanks, Karen. We have a question from Chris. Don't know how to pronounce the name, but I think it's Christian. Do you know something about Novavax vaccine? It's coming to Europe. It contains adjuvant. And is that safe for MS patients or anybody with autoimmune disease? Some doctors in my country are not so sure.
Yes, so Novavax is kind of a throwback to the old way. And so, with all of our current COVID vaccinations, they're some variation of messenger RNA technology. So normally we vaccinate people with some portion of the virus, live virus, dead virus, weakened virus. So you're telling your immune system, here's the virus, make an immune response to it. So messenger RNA was a different technology in that it took a piece of the RNA, the genetic information that codes for the spike protein, your body sees that roadmap for the spike protein and says, okay, I'm supposed to make that spike protein. So you're making the spike protein, your immune system then sees the spike protein, says, oh, you must have COVID. I'm going to make an immune response to it. You never actually had COVID. You didn't have the virus. You just had a manufactured piece of protein that looks like the spike protein. So Novavax is kind of a throwback to the traditional type of technology that we've used. So it's using, and I don't know right offhand if it's live attenuated or dead. Adjuvants are things that you give that help generate a bigger immune response. And I get where researchers could say, and clinicians could say, well, do we really want to generate a bigger immune response in people with an autoimmune disease? So I don't know that we have the final answer on that. I think right now I would, because we've got a little bit of a track record and history with Moderna and Pfizer, I would probably tend to stick with those for right now. Once Novavax comes out, whatever the MS body is in Europe or here in the, let's say Novavax was available here in the States, those MS associations are going to put together a panel, just like the National MS Society did when the messenger RNA vaccines come out. They're going to put together a panel of experts to say, listen, in these studies with whatever vaccine you're looking at, there is a very low likelihood that they included people with multiple sclerosis in those studies. In these studies, they tend to exclude people with autoimmune conditions. So if we don't have hard data to say, what does this look like in people with MS? What's our best guess? So knowing what we know about the vaccine, knowing what we know about MS, would we predict it will look like? So I would expect that sort of statement will come out once Novavax is approved, if it gets approval.
Okay. Lisa also has her hand up, and I'm going to see if I can.
Am I unmuted?
Yeah, we got you.
Okay. So when I was diagnosed in 2006, it was a year and then 2 years after I'd had a case of shingles and then a case of whooping cough that each lasted, the effects lasted 4 to 6 months on each time. When I was in high school, I had a terrible case of mononucleosis. Before we had the vaccines, I had COVID, and it was the sickest I'd been since I'd had the mononucleosis case in high school. Did not have to go to the hospital though. Now I have, and I'm pretty sure I had the Omicron also later, but it wasn't bad because I already had three shots. Now I'm concerned about, are you seeing people having exacerbations after having COVID?
So we've definitely seen pseudo exacerbations. So again, when you get COVID, your immune system does things to try to fight it off. And so there are chemical messengers called cytokines. And so one of the cytokines that the human body uses to fight off viruses is gamma interferon. Gamma interferon is necessary as an antiviral, but it's not your friend with multiple sclerosis. So, it's going to make old MS symptoms act up. So I have not seen a true exacerbation, but I've definitely seen pseudo exacerbations provoked by the viral infection and the immune response to it. And that's not to minimize the severity of these symptoms. So even though we call it a pseudo or false exacerbation, it doesn't mean the symptoms are minimal. They can be pretty significant and they may last a bit. I think that's where we get into the challenge of, how do you separate out as lingering pseudo exacerbation symptoms in a person with MS from long haul COVID type symptoms? And I don't think we have the answer to that. Right now, it may not matter too much because there's no specific therapy for either. It's supportive care, rehabilitation if you need it. But let's say that there's a treatment that comes out for long haul COVID. It may be important someday that we try to tease those out. Lingering MS pseudo exacerbation symptoms versus long haul COVID symptoms. Just a quick aside on the Epstein-Barr virus. So there was, I don't know if people caught, big breakthrough on the Epstein-Barr virus multiple sclerosis link. So we've always known that Epstein-Barr virus is one of a number of viruses that can fool the immune system. So MS is a result of genetics and environment. And the environmental piece is part of that is common viruses that we're all exposed to. So Epstein-Barr virus, we've always known that if it hits your system at just the right time, in a genetically susceptible individual, that it can fool your immune system into going down this autoimmune disease pathway. Well, what happened last month is that researchers at Stanford, had a huge breakthrough. They discovered the specific protein on the surface of Epstein-Barr virus that is responsible for that molecular mimicry. And they discovered the antibody that the protein on myelin that the antibody is reacting to. So now we understand, the proteins on the Epstein-Barr virus and the proteins on the myelin and what antibody is being produced. That could have big therapeutic potential. So it might lead to new therapies coming down the line. So hats off to the folks at Stanford for that research. It was I think a big step forward in taking us past we know Epstein-Barr virus is important to now we know specifically what it's doing.
Thank you, Lisa. Katie would like to know how common is tinnitus in MS? I've had really annoying loud white noise for about 7 years and only recently being assessed. Does it ever go away?
Yeah, so tinnitus or ringing in the ears, is usually a result of something damaging the eighth cranial nerve, the auditory, vestibular auditory nerve. We see it in MS, but it's not a common symptom with MS. And why the eighth nerve is not picked on more with MS than it is a little bit of a mystery. We don't see a lot of hearing loss in people with MS. We don't see a lot of tinnitus in people with MS. And because it's not a tremendously common symptom with MS, I always like to make sure that someone has seen an ear, nose, and throat doc and probably seen an audiologist to make sure there's not something else going on. Tinnitus can be unrelated to your multiple sclerosis. If it's been present for more than a year, it's not very likely that it's just going to spontaneously go away. So I think that's, again, you want to get evaluated by an audiologist and an ear, nose, and throat physician and make sure that there's not something else going on. Sometimes tinnitus goes along with a little bit of high frequency hearing loss in some people, so those two can go hand in hand. Other diseases like Meniere's disease can sometimes cause tinnitus along with vertigo and hearing loss. So yeah, it can be part of MS, but it's not a common symptom with MS.
Thank you. Judy said, I'm seeing some weird stuff from people who have varying autoimmune diseases and developing other autoimmune diseases shortly after getting boosters. She wanted to thank you for your response.
Yeah, so I think that is something we are monitoring. So when you get a vaccination or a booster, we are asking your immune system to do something. We're asking your immune system to mount a response as if it had the virus. There's a fine line between getting that desired immune protection from the virus versus not taking that a little too far and actually causing an autoimmune response. So we've known forever that other vaccinations, doesn't matter which vaccine you look at, so influenza, measles, all vaccines carry some risk of provoking an overactive immune response. And so that's, in some people that could look like Guillain-Barré syndrome. There are cases of transverse myelitis, Bell's palsy, immune platelet issues. The risk is very low with vaccination, and it's not surprising, I think, that COVID vaccines could be associated with a small risk of those autoimmune reactions. Usually the virus that you're trying to prevent, the viral infection, is also associated with those same autoimmune responses. And in most viral infections, if you look at the risk of that autoimmune response from the viral infection versus the risk from the vaccination, it is almost always higher with the viral infection. So again, it's that risk benefit ratio. You know, there was a physician early in the COVID pandemic, I think he was in Florida, if I'm not mistaken, a young, healthy physician who died of a low platelet problem after COVID vaccination. And it was very definitely linked to the COVID vaccination. But when you look at the risk of that low platelet problem after vaccination, that risk is way higher with COVID infection than it is with vaccination. So yeah, it's again, it's all comes down to risks and benefits.
And I know that a lot of what you just discussed is in this question, but there might be something else that you can add to this. This person said, what are the potential side effects and contraindications of the COVID therapeutics, especially for MS patients who may or may not be on MS drugs?
Yeah.
Anything?
So I don't know of any contraindication to the monoclonal antibodies. I mean, you could say if someone had an allergic reaction to, say, the Evoshield, well, that would be a contraindication to them getting Evoshield, but how would you know? You've never received Evoshield. So I don't know of any specific contraindication to monoclonal antibodies. The therapeutic ingredients in Paxlovid, it's also a combination drug. It's an antiviral drug combined with an agent that slows down the metabolism of that antiviral drug. You could say, well, if you've had an allergic reaction to that, you probably shouldn't receive it, but the person would never have received this, so they have no way of knowing if they're allergic to it. Based upon the mechanism of action of Paxlovid, I can't think of any specific contraindication for people with multiple sclerosis. So I think the good news is, I think people with MS, if they need a therapeutic, whether it's an antiviral oral agent like Paxlovid or a monoclonal antibody, I think that they are just as much of a candidate for those therapies as the non-MS community.
Laura is asking, have you heard of any issue with Evoshield if you have heart issues?
So Evoshield, I would have to look up the package insert. I mean, if you had really bad coronary artery disease because of the potential for allergic reactions, you might be a little bit nervous about it, but I've not seen any specific contraindication. Again, I'll circle back to that when we looked at the package insert before we started giving it here, other than the allergic reactions. So when we do Evoshield, we have a little, sort of just in case pack, right there. So we've got epinephrine, Benadryl, steroids, just in case the person had the allergic reaction. I guess, again, if you had severe coronary artery disease, maybe an arrhythmia, you'd worry a little bit more about the effects of an allergic reaction. But again, I think that risk is pretty low.
Okay. Sherry would like to know, do you need to adjust dosing timing in relation to Evoshield? Do you need to wait a month after injection, or is there no risk of dosing near B-cell depleter?
Yeah, so none that we know of. In fact, so our protocols, we're giving Evoshield on the same day as B-cell infusions. So when you think about what B-cell therapy does and what Evoshield does, I can't think of any reason why. There's a rationale behind putting some space between your B-cell infusion and a vaccination, because with your vaccine, you're asking your immune system to do something. You're asking your immune system to make a B and a T-cell response. And if your B-cell therapy is potentially lowering that B-cell response, it does make sense to maybe wait. Hold on, let me hang that up. To wait a little bit between your Ocrevus infusion and vaccination. That really doesn't, 2 seconds, sorry. To wait a little bit between it makes sense to wait between B-cell therapy and vaccination, but not with the Evoshield. Again, I apologize, on a conference call. Makes sense to not have to wait with the Evoshield, because with Evoshield, you're not asking the immune system to do anything. So we're doing Evoshield on the same day as the B-cell infusions.
Okay. So I'm still dealing with MS and comorbid condition vaccine reaction 11 months after my first Pfizer, basically rotating through my greatest hits symptoms. I haven't gotten a second shot. My sister with MS did get the second shot and had definite progression. I have filed a VAERS report, no response. Who is doing the research on this? I have had issues with other vaccines previously too, so it may be adjunct.
Yeah, so VAERS, just so people know, is that's the Vaccine Adverse Event Reporting System. So, and anyone can access that. So you can Google VAERS and go to their website. So it's a way that you can report your data. Normally, so if you are on, a prescription drug and you have an adverse event, the way that that's supposed to work is the physician gets a form from the drug manufacturer, and we fill that out. Here's what happened. That's not really happening right now with the COVID vaccines, and so the research is being done through other channels. I don't know what's going to happen with you reporting that to I don't know if they're going to reach out to you or not. The data is in there; it is collected. So when we think about COVID vaccinations, if someone tells me that they've had a horrific reaction to a flu vaccine in the past, even though COVID vaccination is totally different than a flu vaccination, it's still an immune response. You're generating an immune response to something that we've given you. It makes me a little nervous in those individuals. If someone says, yeah, and I've had people say I was hospitalized for worsened MS symptoms after a flu shot. Even though the COVID vaccine, again, is different, I'm a little leery about giving that person, recommending they get COVID vaccination. So I think that may be where something like Evoshield comes in. So we've tended to think of Evoshield, being administered in people who don't make antibodies because of their MS therapy. Well, what if you can't get a COVID vaccine? Either it's contraindicated, or like this person, they've had prolonged side effects after COVID vaccination. If they want to up their game and be protected at this point, I would probably have them take a look at Evoshield for passive protection. Again, you should not have that same sort of immune response to Evoshield because it's all passive antibodies that you're getting.
Caroline would like to know, if you're on Jolenia and Evoshield is still not available in my area, would you recommend a third booster if you had the J&J vaccine?
I would. I think that's reasonable. Again, my level of nervousness is probably highest with our B cell therapy patients compared to, say, a Jolenia or S1P type therapies. So I do, even though the antibody response might be somewhat attenuated in a Jolenia patient, you're still getting that T cell response. And if Evoshield is not available to you and you've tolerated your J&J, I think it's worth going ahead with a booster dose to just try to get as much protection as you can.
Okay. Marta would like to know, she's had 2 vaccines plus the third booster and got COVID on January 4th, 2022. I received monoclonal antibody infusion at that time. Do you recommend I receive the flu vaccine before getting Ocrevus on March 8th?
So flu shot, I think, is a good idea, for most people every year, obviously. So so if you're on Ocrevus, you would like to think about, trying to do those flu shots or any vaccination as much in the halfway point as you can. So kind of 3 months. That's not always practical. Yeah, I don't like to see people get a vaccination 2 weeks on either side of their Ocrevus infusion, not because it's not safe, because you just might not get the full benefit of the vaccination. So if you can, try to get your vaccination at the midway point between Ocrevus infusions. If you're not on Ocrevus, so you're just starting it, then you'd ideally like to have as many of your vaccines done 6 weeks prior to starting your Ocrevus. So she got monoclonal antibodies to treat COVID, so she should have good COVID protection, again, for 6 to 8 months from those monoclonal antibodies.
Thank you. So everyone, that's all the time we have for now. If you've missed any part of this conference, it'll be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page and our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be next Thursday, February 17th at 6:00 p.m. Eastern Time. The speaker will be Dr. Kalina Sanders, who in honor of Black History Month will be discussing MS in the Black community. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Ben Thrower, who was kind enough to take time out of his busy schedule, as he does every month for us, to share this information. And I wish everyone a good night, and everyone, I'm hoping to see you next time. Thank you.
Bye, everybody. Take care.